routine evaluations, some of the tests you may see patients getting once they're out of the hospital, or even if they come to inpatient rehab, and there may be some tests that we recommend while they're here. And then spend the majority of the time talking about just general preventive measures to prevent another ischemic stroke from happening. And then at the end, just spend a few minutes talking about specific techniques related to very particular causes of stroke in the first place. So we tend to think about strokes as being one of kind of three main subtypes, and then there's a few kind of miscellaneous categories. So the main ones that we focus on are the large artery atherosclerotic strokes. So these are ones that you have a narrowed carotid artery or a significant plaque in one of the major arteries in the brain that either blocks off the vessel itself, or you get the plaque ruptures and you get a clot formation that can either stay there and block the vessel, or goes on to a smaller vessel further downstream. Cardioembolism is probably the second most common cause, so that could be somebody with atrial fibrillation who forms a blood clot in their heart and it breaks off. Could be a problem with like a mechanical valve, any number of sources, but a clot that starts in the heart and travels to the brain. And then a small vessel occlusion, so these are your small lacunar strokes. They are deep in the brain, in areas like the basal ganglia and the thalamus and the brain stem. These are caused by usually high blood pressure for years, leading to progressive narrowing of these very tiny penetrating arteries in those deep parts of the brain. And so those are the kind of the three main well-defined causes. Then there's sort of a grab bag category of stroke of other determined etiology. So these are your less common causes, things like a dissection of an artery, or somebody who has maybe sickle cell disease, or some other cause. It's not really common, but we think we know why somebody had a stroke. And then the last category is of stroke of undetermined etiology. So we used to call this cryptogenic stroke, and you'll still hear that term. But there's really sort of a subset of patients even in this group. So some of these patients, they may have a stroke for a variety of reasons. Maybe they have a high-risk cardiac source, but they also have a tight carotid lesion or something like that. And we're not quite sure which of those is the primary factor. Or they may have a negative evaluation. These are sort of the truly cryptogenic strokes where we've done a thorough evaluation, we've looked everywhere we could possibly think of, and we really still can't come up with an explanation. Unfortunately, that group is still probably 20 to 30% of the patients we see. So despite advances in diagnosis, and there's a good chunk of patients that we just don't understand why they have their strokes. I'm going to talk about a specific subgroup of that called ESIS, which stands for embolic stroke of undetermined source, a little bit later in the talk, and that's kind of a growing topic of interest in the stroke world right now. And then the last could be undetermined just because they didn't have an incomplete evaluation. So we see this not infrequently in stroke clinic, where maybe somebody was admitted to a small community hospital where they got a CT scan but never got an MRI, maybe never got vessel imaging, haven't had an echocardiogram, any of these types of things. So we don't really call that undetermined etiology in the sense that it hasn't been a thorough enough workup to say we don't know what caused the stroke. So that's kind of the framework that I'm always thinking about when I see patients in my clinic. My number one question is, why did this person have that stroke? I mean, that's important because that helps us prevent another one from happening. So now I'm going to move on to sort of our routine evaluation of stroke patients and trying to get at what some of these underlying causes are. And I tried to break it down into a table just to make everything fit together and easy to remember. So I have kind of routine evaluations that we do on most if not all patients, and then extended evaluations you might consider doing in somebody who, maybe it's just seems a little more unusual, or they have recurrent strokes, or it just doesn't fit your kind of one of your typical scenarios. So the first category of evaluation is brain imaging, obviously. Anybody who comes through the ED door is going to have a CT scan, just about. Most patients these days will have an MRI as well, and I think we would consider that standard of care unless there's some reason for them not to get an MRI. There's really not I put SPECT MRI up here. That almost never is done. So that's kind of reserved for the case where you come in with a funny looking lesion in the brain. You're not quite sure if it could be sort of an atypical looking tumor, or maybe it's a stroke. It's just a little bit up in the air. Very rarely SPECT can help answer that question, just based on the composition and the signal that you get from that part of the brain. You can kind of get some clues as to whether this is ischemia or something else. Vessel imaging is really important. As you can imagine, we want to make sure that there's no narrowing of either the extracranial vessels or the intracranial vessels. So typically we'll see, at least here, either a CTA or an MRA. They're pretty comparable in terms of how sensitive they are. My personal preference is that a CTA is probably a little bit better, particularly intracranially. We tend to see the more smaller distal vessels a little bit better on a CTA compared to an MRA. And the other thing is, an MRA often can kind of overestimate just how narrow a vessel might be. But a lot of times you might just see a carotid ultrasound, and if it's a stroke that's in the anterior circulation, so it's in the territory of a carotid artery, that's maybe enough of a workup. I think the limitations are that you don't see what's going on higher up, so you don't know that somebody with a tight carotid lesion doesn't also have narrowing of the carotid artery or the middle cerebral artery in the brain as well, which may have some implications about treatment. If there's really kind of some concern that there's actually some unusual vessel pathology going on, so typically like vasculitis or something unusual like that, that's when we'll go to a conventional angiogram, digital subtraction angiography, or DSA, you'll see that abbreviated as. We don't really do those here, so if somebody needs that, we'll often send them to Harborview or somewhere else to get that done. Then we often look at the heart, so typically we'll get a transthoracic echocardiogram to look at that. We're looking at the function of the heart, what their ejection fraction is. We're also looking for enlargement of any of the chambers. We're looking at the valve function, whether there's regurgitation, whether there's aortic stenosis, whether there's a vegetation for that matter on one of the valves. If there's really a concern that there's some sort of a cardiac issue going on, then we may also get a transesophageal echo. I think it's really variable from place to place how often those are done. Some places will just jump right to TEE in all their patients. Some places won't do them at all, and I think most of the time I would say it's kind of an adjunctive tool where the TTE doesn't quite give you the answer you need, so you may go on and evaluate a little bit further with the TEE. I think in particular TEEs are useful for looking at the left atrium, and particularly the left atrial appendage. So that's the site where clots often form in patients with atrial fibrillation, for example. It's also, TE is better for looking at the aortic arch. So a lot of people may have a lot of plaque burden in the arch that you don't necessarily see on a TTE, and so TE can be useful for that. It's very important, particularly if it looks like an embolic stroke, that you do some evaluation of the cardiac rhythm. So at a very minimum, you'd get an ECG when they show up to the emergency department. We usually want to get at least 24 to 48 hours of telemetry monitoring while they're in the hospital. And I would say most of the time, if it looks embolic and we don't have a clear explanation once they've left the hospital, we'll end up getting one of these sort of more extended rhythm monitors. So here at the VA, they have something called a Zio patch. You guys probably have seen them. They're basically a sticker that goes over your chest, has some embedded electrodes in it, and it'll basically has an algorithm to detect irregular heart rhythms that they send to the cardiologist to review at the end of 2 weeks. The American Stroke Association says it's reasonable to monitor somebody for up to 30